Bismillahirrahmanirrahim. Today our topic of discussion is Seminoma testes. The table of contents. In this, we will discuss about an overview of seminoma, anatomy of seminoma, and seminoma in general, its classification, terminology, epidemiology, essential features, and risk factors. Types of seminoma, description of each type, clinical features, dictum for any testicular swelling, its diagnosis and diagnostic modalities, tumor markers, AGCC, TNM-S classification, disease management, and long-term follow-up. An overview, cancer of the testes are relatively rare cancer, accounting for approximately 1% of cancer in the male. However, it is important in the field of uro-oncology as it is represent a highly curable neoplasm. The incidence is focused on young patients at their peak of reproductivity. Anatomy, we all know about the anatomy of the testes, but for a brief overview, the testis is the male gonad. It is homologous with the ovary in female. It lies obliquely within the scrotum, suspended by the spermatic cord. The left testis is slightly lower than the right one. The shape is oval. The size measurement is 3.75 centimeter long, 2.5 centimeter broad, and 1.8 centimeter thick. And here is the diagram of the male reproductive system. The weight is about 10 to 15 grams, 2 poles, 2 surfaces, and 2 borders. The descent of testes, it is important regarding as the cryptorchidism is related to the seminoma, so we should know the descent of the testes. Develops at the T10 to T12 segments in posterior abdominal wall from genital ridges, subsequently descend to reach scrotum. Begin to descend in second month of the intrauterine life. Third month, it reaches to the iliac fossa. 4th to 6th month, deep inguinal ring. At 7th month, it is in the inguinal canal. 8th month, the superficial inguinal ring. And 9th month, scrotum subsequently descend to reach into the scrotum, the testes. And the 8th month, superficial inguinal ring. And 9th month, it should be in the scrotum by 9 months or 1 month after the delivery. And in this diagram, you can see the path of descent of the testes, how the normal path of the descent the testes should follow. The both diagrams, it is the original position of the testes and the path of the testes towards its final destination in the scrotum. These are the covering of the testes. We all know it is very important. The skin, the dartos muscle, external spermatic fascia, the cremasteric muscle, internal spermatic fascia, the tunics, the tunica vaginalis, and the tunica albuginea. And this is the structure of the testes. 200 to 300 lobules. Each lobule has 2 to 3 seminiferous tubules. Each seminiferous tubule lined by the different stages of spermatogenesis. This is the stage, which is if it goes wrong, it turns into the seminoma. So that's why it is important. Among the seminiferous tubules are sertoli cells. Between the loop of the seminiferous tubules are interstitial cells produce testosterone. Seminiferous tubules join to form 20 to 30 straight tubules. And the ready testes, network of tubules located in the hilum of the testes, also called the mediastinum testes, that carry sperms from the seminiferous tubules to the efferent ducts. Ready testes gives rise to 12 to 30 efferent duct tubes, epididymis, tube about 20 feet, which is 6 meters long, that is while in the posterior surface of each testis, connect efferent duct to the vas deferens. So this is a diagram showing of what we have discussed. And ductus deferens is also called the vas deferens, extend from the epididymis in the scrotum on its own side to the abdominal cavity through the inguinal canal. And blood supply in the testicular artery is a branch of the abdominal aorta. Testis has collateral blood supply from premenstrual artery and artery to the ductus deferens. And the venous drainage, each vein emerges from the back of the testes, tributaries from the epididymis, and they form the pemphiform plexus. And on the right side, it drains into inferior vena cava, and on the left side into the renal vein. So lymphatics, so they are on the right side, they are interaortocaval region, followed by paracaval and pre-aortic and para-aortic lymph node. On the left side, the pre-aortic, para-aortic nodes, and then into the aortocaval regions. Metastasis, which occurs due to this disease, is the common in the common iliac, external iliac or inguinal lymph node, and usually secondary to large volume of the disease. So if the patient has herniorrhaphy, vasectomy, or other transscrotal procedure, metastasis to the pelvic and inguinal lymph node is more likely. And via the thoracic duct to the lymph nodes and the posterior mediastinum, supraclavicular fossa, and occasionally to the axillary nodes. Contrarectal spread is mainly seen when right-sided tumor is involved, and 15 to 20% bilateral nodes are involved. Nerve supply, sympathetic from T10 via spinal cord, and both efferent for testicular sensation and afferent from blood vessel vasomotor. So we come towards, that was the anatomy, and we come towards our topic today, the seminoma in general. Seminoma is the most common type of malignant pure germ cell tumor of the testicular origin, which is up to 50%, and may occur as component of mixed germ cell tumor. Derived from the transformed gonocyte, consists of cells with well-defined borders, clear cytoplasm, round to polygonal nuclei, and prominent nucleolus. Classification. Three major classification schemes have been in use worldwide. Dixon and Moore, which was devised in 1953, WHO classification, and PUG classification in 1976. Here's a table. I assume you can see. You can see all. And Dixon and Moore in the group 1, the seminoma and the spermatocytic seminoma, and WHO classification, it is in general, and seminomas, spermatocytic seminoma, and all other germ cell tumors. And in the PUG classification, in the seminoma and spermatic seminoma, there is no groups as Dixon and Moore have shown the five groups. The other classification didn't mention, they mentioned in general about the germ cell tumors. So this is another flow chart of the testicular tumors. We can appreciate the sex cord stromal tumor and germ cell tumors. And germ cells have two types: non-germ cell neoplasma in situ derived and germ cell neoplasm in situ derived. So germ cell neoplasma in situ derived have seminoma, which is 50%, and non-seminomatous. And this is again the germ cell which is going to transform into the taking part in the spermatogenesis. The type 1 and type 2, the type 2 goes into germ cell neoplasm in situ, and which goes into the seminoma or embryonal carcinoma, and seminoma can transform into the embryonal carcinoma as well. And this is again the same slide with germ cell tumor and two emphasis, and we should know the how the seminoma and derive from the germ cell tumor and other components of the germ cell neoplasm in situ. So this is again the WHO classification of the testes, in which the germ cell tumor derived from the neoplasm in situ, and the germ cell tumor unrelated to neoplasm in situ, and sex cord tumor. Although it is very important, and we basically classify these tumor on the WHO classification. Terminology: the seminoma is a testicular primary tumor or mediastinal primary. The dysgerminoma, same tumor but primary to the ovary. And germinoma, the same tumor but primary to extragonadal sites such as the pineal gland. Epidemiology: male in the third decade, we say that from 30 to 49 years, third and fourth, rare in greater than 70 or less than 20 years. Seminoma is the most common germ cell tumor, bilateral primary of the testicular tumor. Testicular represents 1% of the male neoplasm and 5% of the urological tumors, with 3 to 10 cases per 100,000 males per year in Western societies. Its incidence has increased during the recent decades, particularly in industrialized countries. At diagnosis, 1 to 2% of cases are bilateral, and predominant histology is germ cell tumor, 90 to 95% of cases. Peak incidence is in the third decade of the life for non-seminoma and mixed germ cell tumor, and fourth decade for the pure seminoma itself. Essential features of the seminoma: most frequent germ cell of the testes present in young men 30 to 49 years, unilateral palpable mass, typically well demarcated uniform neoplasm with characteristic cytological features and background of fibrous septa in the lymphocyte. Germ cell markers are useful in the diagnosis. Prognosis is the stage dependent, with excellent 5-year survival when clinical stage 1. So this is again a table narrating the same things. The commonest variety of testicular tumor, right side is more involved than the left side. Start in the mediastinum, compresses the surrounding structure. Patient present with painless testicular mass. 30% have the METs at presentation. Only 3 have symptom-related metastasis. 90% stain for placental alkaline phosphatase, and AFP is generally normal. Risk factors. So, what are the risk factors of the seminoma? If 7 to 10% due to cryptorchidism, positive family history, high incidence for intra-abdominal testes, low incidence for the inguinal testes, which is 1 in 80. Hypospadia, seminoma is the most common to these patients. 5 to 10% occur in contralateral, normally descended testes. Other risk factors are exogenous estrogen during pregnancy, trauma, infection-related testicular atrophy, subfertility due to decreased spermatogenesis, and Klinefelter syndrome. Types of seminoma. The classical type, which is 85%, anaplastic type, which is 5 to 10%, and rest is the spermatocytic seminoma. So the typical or the classical seminoma, 80 to 85%, more common than other two counterparts. Middle age, placental alkaline phosphatase is 90%. Sensitivity of beta HCG could be raised, and it's very slow growing. So it is grossly, it appears like this. Typically well circumscribed with homogeneous gray-white lobulated cut surface and usually no necrosis or hemorrhages. Mean diameter is 5 centimeters. Histological picture of this typical seminoma: uniform tumor cell with abundant clear cytoplasm, distinct cell border, and large central nuclei with prominent 1 to 2 nuclei. Separated into nest of fibrous septa. We can appreciate here. This is a fibrous septa, we can see, and the lymphocytic and the plasmatic infiltrates in the fibrous septa. And we can clearly appreciate the lymphocytes in this septa. And multinucleated giant cells may be seen, especially in the patient with elevated HCG. Granulomatous inflammation can occur in one third, and when extensive may cause problem in diagnosis. Why is it so? Maybe what I understood is for the TB itself. You can see the giant cells here. Prognostical seminoma, excellent prognosis with 95% cure rate for stage 1 and 2. Now comes the second type is spermatocytic seminoma. 2 to 12% of seminomas, higher chance for bilaterally occurrence. Old age greater than 50 years, does not arise from intratubular germ cell. Placental alkaline phosphatase negative. Extremely low metastatic potential, good prognosis, no race predelication. Gross appearance, usually multinuclear with cut surface that varies from gray, white, and fleshy to tan and gelatinous. Hemorrhages and necrosis may be present, as well as extratesticular extension. The size varies from 1 to 20 centimeters, with more than 70% measuring 3 to 8 centimeters. Microcysts are common. Histology. There are three types of cell we appreciate in this spermatocytic seminoma. Small lymphocyte-like cells, we can see this small lymphocyte-like cell, you can see here, with smudge degenerated appearance and scant cytoplasm. Intermediate cells, 15 to 20 mm, with round nucleus and granular chromatin and modest cytoplasm. These are the intermediate cell we can appreciate here. And giant cell, 50 to 100 micrometer, these are the giant cells, with one or more nuclei and demonstrate filamentous type chromatin. So prognosis of spermatocytic seminoma, vast majority with excellent prognosis, malignant behavior in greater than 1%.
Less than 1%.
Oh, sorry, less than 1%. Anaplastic seminoma, which is 5 to 10%. Middle age, aggressive and lethal, greater mitotic activity, higher local invasion, higher metastatic potential, and higher rate of beta city production. Diagnosis requires the presence of at least three or more mitosis per high path field. The cell demonstrate a higher degree of nuclear pleomorphism than in classic type. The anaplastic seminoma tends to present at higher stage. The morphological features are intermediate between classic seminoma and embryonal carcinoma. This is the histological picture. The histology of anaplastic seminoma. The classic seminoma with three or more mitotic figures per high power field were originally defined as anaplastic seminoma. The tumor cells have abundant eosinophil cytoplasm, we can see. The pleomorphic hyperchromatic nuclei, one or more prominent nuclei, and show brisk mitotic activity. This is the main feature of three or more mitotic figures. So the brisk mitotic activity is the key point here in the anaplastic seminoma, and it is more aggressive in all of them. So the prognosis of anaplastic seminoma, the 10 years relapse-free survival rate for the anaplastic group was 70%. For patient with the relapse-free arterial survival rate with anaplastic stage 1 disease, it was 64%. The clinical features, the most commonly as painless testicular lump, pain observed in 45%, sensation of heaviness if size greater than 2 to 3 times, history of trauma, burned out with meds. Rarely dragging pain is complaint in 1/3 of the cases. May make epididymo or chitis, sudden pain and enlargement due to hemorrhagic mimicking torsion and gynecomastia. Dictum for any solid all patients with solid pump intratesticular mass that cannot be transilluminated should be regarded as malignant unless proven otherwise. Because if it is transilluminated, so we can have this cyst.
We cannot have cyst. We cannot have cyst. You see, if it transilluminates, then it is a cyst. If it doesn't, then it's a solid, right? And the second thing is that intrascrotal mass rather should be painless.
Yes, sir, painless.
So if you have got a person who comes to you with a mass in the scrotum, then the first thing is that you ask the patient for how many days he is actually observing that the mass is rising or is increasing in size, and whether there is any association of pain or not. If the person says that there is a little bit of dragging sensation, and I think that whenever I touch the scrotum, I feel a lot of pain, then this is more of an infective kind of a swelling. It might be because of orchitis. So what we do just to differentiate between these two conditions, one malignant, the other one is infective, is to prescribe antibiotic therapy for probably 7 days or 5 days, and then we ask the patient to come again. We examine the patient again, and if it subsides, that means that the size decreases and the patient feels normal in the sense that there is no dragging sensation and the pain is not there, the tenderness is died down, then this is something which is infective in nature. right? So this is the way we always go about the cases, having symptoms and signs of scrotal swelling.
Should I proceed, sir?
Right. Yes. Yes, please proceed.
Yes, sir. Consequences of metastasis. The abdominal or retroduodenal mets, pain and jaundice with liver mets, lumbar pain due to involvement of psoas muscle, dyspnea, hemoptysis, and chest pain with lung mets, hydronephrosis by para-aortic nodes enlargement, triage sign when left supraclavicular lymph node is palpable, bone pain when in the skeletal mets, 3.5% of the cases may have feature of hypothyroidism due to raised HCG. Uh, pedal edema by inferior vena cava obstruction and unilateral or it could be bilateral. So diagnosis, how we made the diagnosis, we made the generally by history of cryptorchidism or previous inguinal-scrotal surgery or general physical examination, and we get the help of labs by CBC or biochemistry profile, serum assays, which are the tumor markers, alpha-fetoprotein, beta-HCG, placental alkaline phosphatase, surgery, we do radical inguinal orchiectomy, and diagnostic radiology, the chest X-ray, PA and lateral view, CT abdomen and pelvis, and ultrasound for the contralateral testes, and special studies we do the semen analysis. Because as we seen in the risk factors that decreased sperm count is also a risk factor for seminoma.
Yes, we will come to this point later, because whenever we
Right.
prescribe um, some medicine for the treatment of testicular cancer, or we do surgery, there is always a chance of having interference with fertility. So all these patients should have the facility and understanding of sperm banking,
Yes,
so
sir.
that we can make them understand a
Yes, sir.
new, um, say, uh, a new way of protecting their fertile activity. So we have to convince our patients, but what we should have is a bank where these sperms
Yes, sir.
can be stored.
Yes, sir.
So we'll come to that point later.
Yes. The bimanual testicular examination in large testes, nodular testes, we can find firm to hard consistency, loss of testicular sensation, secondary hydrocele, and flat and difficult to feel the epididymis. And general examination for METs. General examination is usually aided by a diagnostic department. In the patient who present with no obvious evidence of METs, a diagnostic and therapeutic radical orchiectomy is usually performed. Ultrasonography is the standard imaging technique used to identify testicular carcinoma. The sensitivity, high sensitivity, but it must be combined with the physical examination to achieve the best to achieve the best result. More than 95% of the testicular parenchymal abnormalities are excuse me online.
जी 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 जी.
Okay. More than 95% of the testicular parenchymal abnormalities are identifiable on routine sonograms, but several other lesions commonly mimic the testicle cancer. Here is the slide showing the testicular the seminoma. The ultrasound of seminoma is seen as the multi-septated area of low attenuation with lobulated outline. We can appreciate there. It is the swelling. This is the hole is the testis, and there is a septated with lobulated outline. On the CT scan, the imaging technique of choice in the staging of a testicular germ cell tumor. Although the diagnosis of large volume disease is readily made on CT, the diagnosis of small volume metastatic disease, which distinguish from stage 1 to stage 2, may be extremely difficult. Using a size criteria of 8 mm or larger in the maximum short axis diameter to define a suspicious retroperitoneal node is associated with high specificity, 85%, but low sensitivity, which is 62%. Results of two large studies have established that between 25 and 30% of the patient harbor occult microscopic mets that cannot be detected by CT. The CT remains the primary imaging technique for assessing response of treatment. Here is the CT, and on the left side we can see the metastasis compressing the aorta, and here also is the coronal sections and the axial sections. We can see that it is of the same patient actually, and there is you can appreciate the PET scan of fluorodeoxyglucose PET, which with CT in primary staging of the germ cell, show that FDG PET is useful for detecting viable tumor in lesions that are visible on CT and may prevent false positive diagnosis on the CT in clinical stage 2 of the disease. However, PET does not improve the staging in the patient with clinical stage 1 disease because it is similar to CT. It is poor at detecting the small volume, which is in sub-centimeters. FDG PET is not able to identify mature teratoma, therefore FDG PET is not recommended in the primary staging of testicular germ cell tumor.
Now, again, I want to add something here. PET scan, which has been lately introduced into the clinical scenario, it has been now debatable whether this should be taken as such in the primary diagnosis of tumors, for instance, in kidney cancer, in prostate cancer, and also in bladder cancer. But what is for sure said for PET scan is its value in testicular cancer. But uh, if you can all mute it so that we can talk easily and understand. Please, all participants should mute their connections. Asan, please mute it.
Dr. Hassan, please mute your mic.
Yes. So I'm just expressing myself that PET scan has got a higher value in urology in the case of testicular cancer. But again, it is not in the primary setting, it is in the secondary setting. Secondary means whenever you have done something in terms of chemotherapy and whenever you have completed your chemotherapeutic protocol for follow up and to see whether there is any residual disease present, which might be for the purpose of salvage surgery, then PET scan has got a very high value. Uh, so in urology, out of all the other organs which are involved in urology, it has got a very high value in testicular tumor management.
In stage 2 and 3 seminomas, especially in the patient with bulky retroperitoneal disease, a bone scan should also be performed, but the EAU guidelines 2020 says there is no evidence to support the use of bone scan for the staging of testicular carcinoma.
Right. And we also follow the same thing.
The magnetic MRI of the scrotum offers higher sensitivity and specificity than ultrasound in the diagnosis of testicular carcinoma, but its high cost does not justify its routine use for diagnosis. It may, however, be helpful to distinguish between an intra and extra testicular mass when this cannot be confirmed clinically or with ultrasound. Currently, there are no indication for routine use of MRI for testicular staging.
Yes, and for all purposes, for instance, if there is a tumor, probably a seminoma in the testis, and there is a possibility that both the testes are involved by tumor, then there is a concept of testis sparing surgery or partial ochiectomy. Now, partial ochiectomy can easily be done with the guidance of ultrasound. Uh, there again, ultrasound gives you a very good picture because testis is something which is in the scrotum and it is very much superficial. Superficial in the sense it's very close to the skin. So you have got a very high resolution of the image, and it can tell you uh, an interface between a normal testis and an abnormal testis, abnormal
Yes.
testicular mass. And whenever that line is delineated by the ultrasound, you can easily do something called partial ochiectomy or testis sparing surgery.
And here is the International Germ Cell Cancer Collaborative Group prognostic risk classification. The risk status is good risk, intermediate risk, and poor risk. The good risk is any seminoma, any primary site, any tumor markers, or no pulmonary visceral mets. The overall 5-year survival is approximately 90%. In intermediate risk, any primary site, any tumor markers, and non-pulmonary visceral mets is approximately 75%. And poor risk does not exist, which is approximately overall 5-year survival rate is 45%. The tumor markers, which are oncofetal substances, which are alpha fetoprotein and HCG, cellular enzymes, LDH, and placental alkaline phosphatase. Other tumor markers are LDH, placental alkaline phosphatase, again GGTP, and CD30.
For all practical purposes, uh, three tumor markers are sufficient, and these are
Yes.
alpha fetoprotein, beta HCG, and LDH. And simply the presence or absence of alpha fetoprotein will give you a distinction between one type of tumor, testicular tumor, and the other. So, Noman, are you there with us, or are you absent today? So, can you say a little bit about the um, importance or significance of tumor markers, because this is your topic also?
In testicular tumor, basically these are the substances which are produced in a biological life by the premium there. Alpha fetoprotein beta H. Another one that LPH is the overall tumor marker well as total burden. And the most important marker is AFP. AFP is just the presence of AFP in the serum in a patient of that tumor. We can easily identify that specific this patient has a specific type of testicular tumor. If AFP is there, only 5 to 10% cases there is chance that AFP also can present in the non-testicular. But AFP is positive. It is for sure. It is it is a seminoma.
Right.
This is for sure. So alpha fetoprotein it is produced by the if HCG is present, if HCG is present and the tumor marker can easily label that patient as non-seminomatic tumor is there, and that type chorion layer of the part of the medium is of MU, but HCG is produced by that. So we can tell that the HCG is there, and non the very good. The other mark of PLAP, PL placental alkaline phosphatase. This marker is done by a medical oncologist or urologist when they plan to give a particular or different treatment, chemotherapy in seminoma or non-seminoma. The other two, there are multiple tumor markers, but these three only HCG and LDH. These are most important as service.
So, for all practical purposes, if we consider the importance of all three, out of all these three, one is the most important, and that is AFP. If you do AFP before doing any treatment of the testicular mass, and if AFP is absent, then that means that this is a non-seminimatous germ cell tumor. Is that correct? Noman?
So if AFP is absent, it is for sure the non-seminal germ cell.
Right. So by that means you will be actually making yourself understandable of the situation before the biopsy comes into your hand, just by having tumor markers. So uh, again for all practical purposes, if somebody comes to you with a testicular mass, scrotal mass and a testicular tumor, you always go about certain imaging techniques. For instance, the most important is ultrasound. I'm just repeating and summarizing the whole topic. And then you do tumor markers. If there is no AFP, we are sure that what it is. If there is AFP, we are sure that what we are dealing with and what we are expecting the histopathology should be. And if HCG is in a very high concentration, then we'll be sure that there are some chorionic cells present, right?
Yes.
Yes, please proceed.
There is a role of the tumor markers we have already discussed, sir, and helps in the diagnosis. And only most of the non-seminomas have raised markers, and only 10 to 15% non-seminomas have normal tumor markers. After orchiectomy, if the markers are elevated, means residual disease or stage 2 or 3 disease.
You see,
Negative
sorry,
tumor.
I just want to stop you here. The second point, most of the non-seminomatous tumors have raised markers. Not all markers,
Okay, sir.
right? You have to consider that AFP is not present. AFP is absent. If you find something which is a normal value of AFP, this is not non-seminomatous germ cell tumor,
Yes, sir.
right? Okay.
And American Joint Committee on Cancer, the TNM staging. Requirement for staging is pathology of the tumor specimen, history, clinical examination, radiological procedure, and tumor markers, of course. The primary tumor, if T0, no evidence of primary tumor, tumor in situ, germ cell neoplasma in situ, and T1, the pure seminoma confined to testes or tunica albuginea, reti, testes, and no lymphovascular invasion. The T1A is less than 3 centimeter. The T1E is greater than 3 centimeter, confined to testes, albuginea, and reti testes. When the lymphovascular invasion occurs, then we will label it T2. And T3 with direct spermatic cord or soft tissue invasion, and T4 is direct scrotal invasion. And I think it's a bit blurred picture, but we can see this here. It's the testes, the tumor is present, or it could be like testes plus epididymis involvement, or the testes with the tunica albuginea involvement, and without vascular or lymphatic invasion, it would be T1, and with vascular or lymphatic invasion, it would be T2. So here it is the into the tunica albuginea. It is T2. And regional lymph nodes, it's and not no lymph node. N1 is 1 to 5 nodes with node size greater than less than 2 centimeter, and N2 is greater than 5 nodes or extragonadal extension, or involved nodes greater than 2 centimeter and less than 5 centimeter, and N3 is lymph node mass greater than 5 centimeter. Distant mets and serum markers. The M1A is no regional lymph node except the iliac, inguinal, and the pelvic or lung mets, and M1B is distant mets include discontinuous spermatic cord or not lymph node. And we discussed about the serum markers, as I told about serum SX is no serum marker, S naught is marker with normal limits, and S1 is LDH to the less than 1.5 and upper limit of the normal. And we can see this.
Just a minute. Just a minute. Uh, yes. You see, for any tumor in the body, we have got a tumor staging process which is known as TNM classification, whether it is for prostate, for bladder, for kidney, if you talk about urology. But this is a special kind of a tumor. Here, this is not only TNM classification, there is TNM-S classification. Now, S is something which should be done before any treatment, and then this is done in adjuvant setting after the treatment has been given. Now, any tumor which is a testicular tumor, whenever it is staged, it should be a TNM-S staging rather than only TNM.
Yes.
When you have done the ocheectomy, then it becomes PT. Small p stands for pathological. If you are taking into consideration all your investigations like imaging, the staging process will be with a small c, and that small c is clinical. So there are two types of stages. One is clinical stage, and the other one is pathological stage. Pathological stage, whether it is for bladder, for prostate, for kidney, for testis, it is always done after you have got a biopsy, after you have done your ablative surgery, right? So for testicular tumor, there is a special kind of TNM classification. Again, I'm repeating myself, and that is TNM-S classification. You should not operate on any patient. You should not do any biopsy beforehand unless and until you have done your S sort of exercise, which means you have to do serum marker estimation, right?
So as sir mentioned, the stage it is divided in the stage group 0 to stage 3C, and here we can see the pathological tumors on the biopsy from T1 to T4, and this shows the nodes, and this M is for the meds as we discussed, and S for the serum marker.
Right. So if you, for instance, if you do this this staging exercise before you have done surgery, then this P will be replaced by C. So you have staged your tumor on CT scan, and you have done your serum markers. Then it becomes CT1 to 4 and not M not SX, right? But if you have included the biopsy, then it becomes PT1 to 4 and not M not SX or whatever.
Yes, sir. In stage 1 disease, one of the most important determinants of the outcome is the presence of vascular invasion in the primary tumor. In stage 2 of the disease, the extent of retroperitoneal adenopathy and serum tumor markers level determine the treatment and outcome. Disease management. These are the steps we follow in the disease management. Approach consideration according to stage of the disease, chemotherapy, radiotherapy, surgical care, tumor boards or intra-departmental consultations, prevention by monthly testicular self-examination starting at puberty, and long-term monitoring. Stage 1, the orchiectomy provides both diagnostic and therapeutic benefits. Orchiectomy alone cures most of the stage 1 seminomas. The NCCN recommends the following as standard option in the stage 1 disease. The surveillance, the single agent carboplatin chemo, 1 or 2 cycles, and radiotherapy of 20 grays preferred or 25.5 grays. Preferred treatment for more advanced stages are as follows. Stage 2A, radiotherapy or chemo with bleomycin, etoposide, and cisplatin, which is called the BEP therapy, or etoposide and cisplatin, which is called the EP therapy. The stage 2B, chemotherapy, which is preferred with BEP or EP or radiotherapy in selection of non-bulky mass, which is less than 3 centimeter. The stage 3, good risk chemotherapy with BEP, category 1 or EP. And stage 2C and 3, which are high risk chemotherapy with BEP or etoposide, mensa, ifosfamide, and cisplatin, which is called the VIP treatment. This is the BEP therapy, cisplatin, etoposide, bleomycin, and this is the common salvage regime for metastasis in germ cell tumors. This is the first line treatment of the which is mostly through the VIP treatment. Sites are cisplatin and etoposide and placitexel, isofosfamide, and cisplatin.
You see, the very positive thing and the good news about this cancer is it is very much chemosensitive. That means if you have diagnosed a cancer at stage 1, probably at stage 2 even, and you have done a good surgery, and you have also done your complete chemotherapy, then mind you, you will have got almost 100% result. The survival rate is too encouraging, and this combination BEP has got its marvelous complete response rate, better than any organ in the body, better than any pathology concerning cancer of any organ. So this is there are many examples. For instance, there was one person, Lance Armstrong, who was once a Tour de France cyclist, and he had got this problem of testicular cancer. He went through this whole regime of testicular management, tumor management, and he was not only up and about, he went again and competed in the same Tour de France cycle race. He didn't won it, but he was actually at it. So that was one positive thing. But then there was another twist in the story, and we'll talk about it later. But the thing is, if you have got a testicular tumor, you come to your doctor early, you have got a very good surgery done, and there is a chemotherapy follow-up. Mind you, again, rest assured that there will be almost 100% cure of the disease. Yes.
Neoadjuvant cisplatin therapy prior to radiotherapy could be promising. Radiotherapy should start once the orchiectomy wound has fully healed and should be given 5 times per week. Radiotherapy is not preferred for stage 1. Long-term follow-up studies indicate an increase in late toxicities. Total dose of 20 grays is delivered in 10 fractions of external beam radiotherapy. For stage 2A, dose is 30 grays. For stage 2B, the total dose is 36 grays. And the targets are the para-aortic, ipsilateral pelvic nodes, and ipsilateral iliac lymph nodes. The surgical care, the retroperitoneal lymph node dissection, and radical inguinal orchiectomy, and as the sir mentioned earlier, the testicular sparring surgery as well. And we can also, the sperm banking should be discussed with the patient of reproductive age, and advice for prostatic testes should also be offered.
Numan, you want to say something?
Yes. So, we were talking about chemotherapy and number of results of chemotherapy. So, I was just want to memorize just want to say that the platinum-based chemotherapy.
Yes.
Before the discovery of platinum-based chemotherapy, the 5-year survival rate of the testicular tumor was very low, 5 to 20%.
Yeah.
And after the platinum-based chemotherapy discovery, the 5-year survival rate, because we don't have any more than 5-year survival rate results of the large studies, the 5-year survival rate jumped from 85 to 95%.
Yes.
It is not 100%.
Yes.
And there are particular different factors, the molecular factors, which help the platinum-based chemotherapy to act so specifically and effectively in the testicular germ cell tumors. I just remember two or three points. Number one, that I can compare the kidney bladder and the testicular tumor. So in these two tumors, we use the platinum-based chemotherapy according to their effectiveness. In the germ cells, germ cells have the specific receptor for the platinum-based chemotherapy or these agents. Once the platinum agents or chemotherapeutic agent enter into the germ cell does not have any receptor or any pusher unit in their cell wall, cell membrane, which can push out the chemotherapy. So when the drug it is still inside the cell, it cannot be pulled out. But in case of the renal cancer, once you give them the platinum chemotherapy, the therapeutic agent once enters inside the cell, those renal cells they push these agents out of the cells. They don't affect in the renal cells. Number one. Number two, the germ cells tumors they have the high amount of the apoptotic genes, pro-apoptotic genes. When there is a cancer themselves, they initiate the protocol. They raise or they produce the vast amount of apoptotic gene and suppress the anti-apoptotic genes. So after giving the therapeutic dose of the chemotherapeutic agent, these pro-apoptotic factors further activate themselves and anti-apoptotic factors they suppress themselves. So they destroy the germ cells completely,
Right.
which are
So
mitotic or which are neoplastic.
yes. So for the benefit of all of us, can you just define what do you mean by apoptosis?
Apoptosis, it is a programmed cell death. You remember that this is a normal mechanism in our all human body. When there is any pathology which is not required by the body, which is harming the body responds in that particular respect and destroy that cell. The programmed cell death of body without damaging the surrounding tissue. It is apoptosis. And there is another counterpart, which is necrosis. In necrosis, this is not a programmed cell death, it's a cell death which involves the surrounding tissue damage also. It can also damage the surrounding tissue. And in apoptosis, and there is when there is any cell which damaged inside from the nucleus side, there are two factors, two things: the pro-apoptotic genes and anti-apoptotic genes. Pro-apoptotic factors or anti-apoptotic factors. Anti-apoptotic factors, these anti-apoptotic factors are normally present in the normal cells, and apoptotic factors are also normally present in the normal cells. In germ cells, when there is any insult inside the germ cell, either neoplastic or any other insult, and this cell is cannot be used properly in the future by the whole organization of cells, then this particular cell's command center will just send signals to this cell and produce the pro-apoptotic genes, and this produces the blebs or enzymes inside the cell and inside the vesicles or micelles. These micelles they engulf the cells organelles one by one, and they do not shatter off their enzymes inside the surrounding cells. And this mechanism is promising mechanism in germ cell tumor, which helps the urologists to cure the disease effectively. More than 95% 5-year survival rate, just only because of these mechanisms, basic mechanisms, which are only the basics of the our previous.
Right. So it is very interesting and very elaborately explained by yourself, Numan. And I'm impressed by the depth of knowledge and clarity of understanding that you have at this stage. What I propose for my personal interest and for the interest of all of us who are listening to you, that you make a presentation on the metallic transport of these cells, the tumor biology of testicular tumor, and how this cisplatin has transformed the whole scenario of chemotherapy, at least for testicular tumor. So once you are ready, then we'll just put your presentation in our virtual classroom, and then we'll understand it more clearly. Can you do it, Noman?
Sir, I'll do it.
So this is your homework. You have made yourself a culprit of your own understanding.
Thank you.
Right. So this might be a punishment for you of speaking too much in the presentation made by a junior person like Faizan. Right.
So
Okay.
random. Thank
So
you for presentation.
sorry, Faizan, we have interrupted. I myself was interested in the subject, and I don't want to market Noman. I want to make it say understandable to all you people that we have got a person amongst us who knows it clearly, more clearer than many of our seniors, at least me myself. I cannot understand the subject more clearer than he himself, because this is a subject also, this is topic of research. So sorry for interruption in your presentation.
No, sir, sir, it's not. It's all fine. You are both my worthy seniors, sir. And it was very actually good to listen, Aman, sir. Very informative. Should I proceed, sir?
Yes, sir.
And in the long-term follow-up, for the patient who have undergone orchiectomy only, the schedule is as follows. First year, history and physical examination every 3 to 6 months, CT at 3 and 6 months and 12 months, and ultrasound testes. Whenever ultrasound is mandatory whenever the patient visits in the follow-up. And the second year and third year, history and physical examination, CT every 6 to 12 months and ultrasound testes. Fourth year and history and physical examination annually, CT every 12 and 24 months, and ultrasound along with it. And for patients who have received adjuvant chemotherapy or radiation, the schedule is as follows. The first year and second year, the history and physical examination every 6 to 12 months. CT should be done annually along with the ultrasound for the testes. The third year should be the history and physical examination and CT annually with ultrasound of the testes. And fourth and fifth year, the history with physical annually and ultrasound of the testes. We are discussing all this in the 5-year overall survival rate.
Right.
For the patient with stage 2 and non-bulky seminoma who have undergone through chemotherapy or radiation therapy with no residual mass or residual mass greater than less than 3 centimeter and normal serum tumor marker levels are year 1 history and physical examination every 3 months, CT at 3 and 6 and 12 months, chest every 6 months. In the second year, history and physical examination every 6 months, CT annually, chest X-ray every 6 months. For third year, history and physical examination every 6 months, CT annually. And fourth and fifth year, history and physical examination every 6 months, CT as clinically indicated, and ultrasound testing is mandatory on every visit. And yes, for the patient with bulky stage 2B, 2C, and stage 3 seminoma who have undergone through chemotherapy and no residual mass or residual mass greater than
Less than.
less than 3 centimeter and normal serum markers levels. CT and PET are done if clinically indicated. CT just if chest symptoms are present. First year history and physical examination, markers and chest X-ray every 2 months, ultrasound testes. And in the second year, history and physical examination with markers and chest X-ray every 3 months, along with the ultrasound. And third and fourth year, history, physical examination and markers every 6 months, and chest X-ray annually, and ultrasound testing. At the fifth year, history, physical examination, markers and chest X-ray annually with ultrasound testing. These are my references, and thank you very much.
Thank you, Jay. Excellent. Again, an excellent excellent presentation and very eloquently put forward. Now, if I want to just add my colleagues into the discussion. Uh, Anybody can ask any question from me or the presenter, if you all are listening.
Yes, yes.
It's open. It's open. The forum is open now. Assalamu alaikum. Ji.
Sir, I want to ask a question, sir. You said in the diagnostic workup that AFP is the main tumor marker which we are assessing.
Yes.
But in the staging slide, he has mentioned LDH. All there was mentioned LDH, the staging, and what is the difference between it?
You go back, Faizan, to that slide, the staging process.
This one?
No, the one which we mentioned LDH. Yes, this one.
This one?
Yes, sir.
Right. So you see, if you go from top to bottom, I just read it through. SX means that serum tumor markers not available, not performed. We all know that. S naught means that the markers, all three markers were normal. S1 means that the LDH is less than 1.5, the upper limit of normal, which is the upper limit of normal. HCG, again, this is the second marker. It should be less than 5,000 micro international units per ml, and AFP is less than 1,000. So all three are taken into consideration. What my argument at that point was, when we were discussing all three markers, the more important or the most important differentiating marker is AFP. If it is absent, then there is one thing which in your differential diagnosis is gone, and that is non-seminomatous germ cell tumor. All other things will remain in your differential, but one thing will be gone if AFP is not there in your estimation, right?
Okay, thank you, sir. Yes.
So in that way, you will be able to judge that the tumor you are actually doing surgery upon will eventually be something else. For instance, if AFP is not estimated or is not measured, it is unmeasurable in your serum sample, then the thing which will be coming into your perspective would be non-seminomatous germ cell tumor. It will not be seminoma. If AFP is there, then it will be seminoma, and then according to the concentration and its value, you will follow whether it is increasing or decreasing after you have done some surgery or chemotherapy.
Okay, thank you, sir. Got it.
Okay. Any other question?
So I just wanted to ask. I was when I was making this presentation, and I was just for the radiology purpose, I was just searching. There was PET scan, and what is a SEMPET? SEMPET trials, SEMPET trials. It was mentioned. I didn't get.
SEMPET.
Yes.
Noman, do you know it? I don't know about it. I haven't heard about it.
Yes, this thing. I mentioned it, but I didn't know
SEMPET
exactly
trials.
what these trials are and what these things.
Maybe
These
this is.
are name of trials.
Maybe this is some kind of a trial which is being done by our radiologist. We have to look into it, and then I will just put it on the post, the WhatsApp group, what it is, if I find
Yes.
out. Right. So, any question? Anybody wants to say anything regarding the topic?
I saw
Yes.
Seminoma, they have three types: classical, anatomical, and
Spermaceti.
spermatocytic.
Spermaceti.
They have their their but this is just the classification for the and in the book I was just that we see that the one thing about the testicular distance. So there are four things
your voice is not clear. We can't hear you properly.
Hello.
We can't hear you properly.
One thing about the management of that seminomatic tumor is number one, the objective is therapeutic and diagnostic both at the same time.
Right.
And after the and this is the only tumor, not only tumor, it's the tumor related and also we can change them between the tumor. And there is one thing I want just to add or ask for the doctor. There is a thing as I was mentioning when I was like presentation part of using the testicular self-examination, because in
Right.
abroad they propose and they force it to point test self-examination. It is the same but as the breast self-examination in the female.
Yeah.
We can feel the lump or any pain or any abnormality after examination of our own testis. There's a proper way to examine.
Yes, and I think I've got one infogram regarding this testicular self-examination. I will look for it and then repost it on your study group also, so that everybody should see it as the topic is being discussed today, so that we can see it today and we revise ourselves. Yes, Shesha, you want to say something?
Sir, how likely is testicular mass going to be disseminated or spread out inside the body if it is handled manually again and again? Because we've read that testicular mass should not be fondled with.
There is no clear report, any randomized control trial on that aspect, that if this tumor is handled again for examination purpose by the person himself or by the doctor, then it leads to dissemination. Whenever we read something in the textbook saying that when for instance, if you are operating upon a person who has got a kidney cancer, don't fiddle about the kidney cancer, just go towards the vessel first, tie down the vessel, and then do the dissection of the tumor later, or of the kidney later. But you see, whenever somebody wants to do surgery, he has to make it a point that um, he must be pretty sure that the morbidity on the table should be as less as possible. Morbidity means bleeding should be as less as possible. Uh, if the tumor is very much adherent to the surrounding structures, then you have to make your way towards going on to the hilum. Unless and until you do a little bit of dissection, it will not be possible for you to narrow down to a point where you can take out the vessels first. So you always move around from the periphery, narrowing down to the vessel, and in that way you have got the a little bit of maneuver to do so that you make your way. The same goes with testicular tumor. Unless and until you palpate it, you will not be able to judge a lot of things. For instance, one very important thing is tenderness. Now, tenderness is something which is elicited. Unless and until you put a hand on the scrotum of the patient and see the face of the patient yourself, you will not be able to judge whether this is tender or it is not tender. So, with gentleness, one has to do it. So that answers your question, perhaps
Yes, sir, thank
a
you.
little bit.
Yes, sir, thank you.
Right. Any other person who wants to come in and join us? Right. So this, I think, is the end of today's session, and I again congratulate Faizan, because this, to my understanding, is one of the difficult topics in urology. This is a topic which normally the urologists don't like to discuss, because this is a topic which is too difficult to understand from beyond surgical aspect of the disease. Um, there are not many people who can do retroperitoneal lymph node dissection or retroperitoneal lymph node lymphadenectomy, because that carries with it a lot of morbidity as well as a little bit of mortality also, because all these retroperitoneal structures are very much close to the sympathetic chain. Whenever you do surgery, you have got inadvertently do sympathectomy. That has got a very grave consequences in later life for the patient. So nobody wants to delve into an area which is rather too difficult to get into. But now there are some possibilities. There are some other approaches to the same problem that I'm mentioning, that is a retroperitoneal space. I can post something on your WhatsApp group regarding the placement of trocars for the um, purpose of robotic lymph node dissection in retroperitoneal space. That has come up very lately, perhaps yesterday or day before yesterday. I've gone through that aspect of disease management. So there are some challenges again, and there are some challenges in this context of testicular tumor and metastatic testicular tumor with lymph node involvement. And these challenges are only be dealt by those who do it time and again. So this is a case for those centers who have got a very high volume of disease. This shouldn't be done. For instance, lymphadenectomy, retroperitoneal space should not be done by any person who does it once a year. Any person who does it should do it at least twice in a month. It might not be possible to do it once a week, but in a month, we have got maybe 1 or 2 cases where these things can be done. So our team dedicated for this purpose can always have good results, can always have less morbidity, and that is what we want for our patients. Yes, anybody wants to say anything? There are 2 raised hands. Ji. Zishan, you want to say something?
Hello.
Ji. Zishan, you want to
Hello.
say something? Ji, ji. We are listening to you.
So I have a question. I want to ask, what is the favorable organ for distant mets in seminoma?
Favorable organ
If
for
it's-
distant mets in seminoma. The organ is not clear. Any organ can be involved, but retroperitoneal space is the one that is mainly the area of its fallout, and lymph nodes are the ones which are the better drainage sites. So normally what we see is not an organ. Yes, there are some places which are extra gonadal affinity for germ cell tumors, but mainly it's the lymph node and conglomerate of a lot of lymph nodes in the form of a mass. Okay. Yes, any other question? Right. So we'll just say Khudafis, and we'll meet not tomorrow, but day after tomorrow on Saturday, and I think it will be Gulrez on surgical management of urolithiasis. Right. And from yes, and today and yesterday also I posted something for the round 2 presentations of those who have been through this round 1. For instance, now there are 4 people who have been through this round 1 presentation. So the round 2 presentation will always be a link between this presentation and the other presentation. So we'll be able to judge it more detailed discussion, so that we must understand the whole gamut of the disease. Shersha, want to say something?
No, sir, I didn't raise the hand.
Achha. Right, so okay. So Khudafis, and we'll meet on Saturday.